Physical and cognitive development in adolescence. There are 5 main physical changes in adolescence as the endocrine and central nervous systems develop. And some of these changes begin before they can be seen, some of them actually occurring in utero before birth. The first main physical change is rapid growth spurt, with marked changes in height and weight. Adolescents experience a growth spurt which is followed 1 to 2 years later by puberty. This growth spurt peaks 2 years earlier in girls than in boys. Girls experience the peak of their growth spurt at the age of 11 years, boys at 13 years. Girls begin puberty at 12, boys at 14. Thus, girls mature physically 2 years before boys do. Girls are generally a bit taller and heavier than boys from ages 11 to 13. By age 14, boys are taller, heavier, and stronger than girls. The torso increases in length more than the legs do, and the head, hands, and feet are the first to display a growth spurt. All the parts of the body do not grow at the same time or rate, giving adolescents that gawky appearance you may all affectionately remember. The second main physical change, development of the gonads, the sex glands, the testes in males and the ovaries in females. The third main physical change is the development of secondary sex characteristics, or physical changes outside the reproductive system. Included are changes in the genitals, breasts, skin texture, and voice, and growth of hair in the pubic area, face, and other areas of the body. Pubic hair appears 2 years before underarm hair in boys and girls, and 2 years before facial hair in boys. In the male, and to a lesser extent in the female, the voice deepens in later adolescence. Breast changes occur in girls and to a lesser extent in boys. The fourth main physical change in adolescence is the change in the amount and distribution of fat and muscle. In the male, there is increased muscle development in the neck, chest, and shoulders. In the female, there is retention of a higher proportion of fat to muscle, enlargement of the breast, and broadening of hips. Males have a 3-to-1 ratio of muscle to fat. Females have a 5-to-4 ratio of muscle to fat. The fifth main physical change in adolescence is change in the circulatory and respiratory systems, leading to greater strength, especially in males. These system changes include increased size of the heart and lungs, increased ability of the blood to carry oxygen, increased ability of the body to neutralize lactic acid, a waste product of physical exertion, increased number of red blood cells, higher systolic blood pressure, lower resting heart rate, and higher blood hemoglobin. Puberty includes the physical changes an individual goes through from childhood to adulthood. It is a period of rapid physical maturation involving hormonal and bodily changes that occur primarily during early adolescence. Puberty leads to reproductive ability. Girls experience menarche, or the first menstruation, at about 12.5 years. Boys experience spermarche, or first ejaculation, at around 13.5 years. Onset of puberty begins at conception and progresses gradually. The onset of that part of puberty associated with adolescence depends on the release of certain hormones, with a timetable that is predetermined by genetics. Environmental events like nutrition, stress, and excessive exercise can influence the onset of puberty, as well as body mass, psychological health, and physical health. Generally, an adolescent girl must weigh more than 100 pounds, and her body mass must contain 17% fat in order for the first menstrual period, or menarche, to begin. Extreme thinness can delay the onset of puberty. Obesity can bring it earlier. No new hormones appear at adolescence to usher in adolescent puberty. The hormones that have been around since before birth just change in amount. Some increase, some decrease. No new hormones appear. Hormones both organize and activate. Organization occurs in the womb when hormones shape the developing brain in ways that will predetermine behavior in years to come. There is a sex difference in brain organization. For the first 7 or 8 weeks following conception, the developing brain is feminine. Things do not change unless there is a Y chromosome present to trigger greater quantities of testosterone and other hormones associated with maleness. Sex differences in aggressive behavior may not be displayed until adolescence, but are more likely the result of prenatal hormones rather than hormone change at puberty. Just because the alarm clock set years before for certain behaviors rings at the same time as hormone levels change in adolescent puberty does not mean that adolescent puberty and the hormonal changes therein cause the alarm to go off, triggering the behaviors. Hormones act as activators as well as organizers. Hormone changes affect behavior like increased sex drive. Increased sex drive happens once there is adrenal gland activity. Sexual attraction feelings are thus possible once the adrenal glands mature in a process called adrenarche, which precedes full-blown puberty. Changes in levels of certain hormones at adolescent puberty will trigger or activate the development of secondary sex characteristics. Some behavior changes are the result of an interaction of the organizational and activational effects of hormones. Prenatally, an individual is programmed to behave in certain ways, like sexual behavior. But it is not until this behavior is activated at puberty by certain changes in hormone levels that the behavior can take place. A person has the brain organization that determines sexual behavior, but does not have the motivation to engage in this sexual behavior until after the hormonal changes of adolescent puberty. The system in charge of production of hormones is the endocrine system. Endocrine glands produce and distribute hormones. These secreted hormones selectively target certain areas. But the system in charge of monitoring levels of circulating hormones is the central nervous system, the CNS. The brain, in particularly the hypothalamus, acts like a thermostat. It will inhibit stimulation of the pituitary gland of the endocrine system when a decrease of a certain hormone is needed, and it will stop inhibiting the pituitary when an increase is needed. At puberty, the hypothalamus becomes less sensitive to the sex hormones and allows the levels of sex hormones to increase without inhibiting the pituitary. So in effect, the hypothalamus prevents or inhibits puberty until adolescence, when the hypothalamus becomes less sensitive to the sex hormones. Both males and females have male androgens, and both have female estrogens. In adolescence, males produce more androgens, and females produce more estrogens. Anabolic steroids are synthetic versions of the hormone testosterone that some teen athletes use to promote larger muscle growth. But performance improvement is questionable, and side effects are serious. In women, voice deepening or baldness can occur. In men, shrinkage of testicles, sexual impotence, or breast enlargement can occur. In addition, there is an increased risk of heart attack, stroke, and liver damage, and for younger adolescents, stunted growth. For some, the picture is even worse, as steroids may cause mania, suicidal depression, and antisocial behavior. Let's talk a bit about the psychological and social impacts of puberty, since puberty has a psychological and a social impact as well as a biological one on development during adolescence. Today, our social attitudes about menstruation, feminine protection, masturbation are more open and less conservative than in years past. This is evidenced in the way society expresses its views of puberty in advertisements, films, TV, newspapers, magazines, and the Internet. Puberty affects behavior both directly and indirectly. It does so directly by increasing hormone levels. It also affects behavior indirectly by altering an adolescent's self-concept, self-esteem, and appearances. Self-concept is the picture held of self, and self-esteem is the value placed on this picture. Puberty alters self-concept by making an adolescent more modest and self-conscious. Young adolescents have a preoccupation with their bodies and physical image. They practically wear out mirrors as they evaluate their looks again and again each day. Just notice how teens check themselves in every mall store window as they pass. They're not looking at the mannequins and merchandise. They're looking at their own reflections and checking their hair and clothes. Besides altering self-concept and the picture held of self, puberty also indirectly affects teen behavior by altering self-esteem. Self-esteem refers to the value judgments that adolescents place on self-concept or the image that they have of themselves. Girls tend to be more negative and critical about their body images than do boys. Decreases in self-esteem are more likely for girls who hit puberty at the same time that other transitions occur, like entering junior high school or dating. In addition to affecting behavior indirectly by altering self-concept and self-esteem, puberty also indirectly affects the behavior of the adolescent by changing his or her appearance, and thus affecting how others treat him or her. A person who looks older is treated differently than one who looks younger, resulting in differential behavior. There are other psychological and social impacts of puberty in addition to alterations in self-concept, self-esteem, and appearance. Puberty and the physical changes it brings also alters mood and alters the relationship with parents. As for mood, abrupt and variable increases in hormone levels in early adolescence may account for increased irritability, aggression, impulsivity, and depression. However, environment appears to be far more responsible than biology and hormone levels. Stressful life events and activity changes influence mood swings. These mood swings have been shown to be directly related to changes in activities, the environment. Bored in class, happy with friends, etc. Adolescents change activities and settings more frequently than adults do. Also, moods are related to the sleep preferences of adolescents, who tend to prefer to go to bed late and to sleep late. School starts early, and adolescents are required to be alert early, while their natural alert peak happens after 3 p.m. when school ends. As for relationship changes, there is more distance between adolescents and their parents, more conflict, complaints, less smiling. There is a different balance that needs to be established, as teens expect different treatment than they received as children. Developmentally, they are changing to want more say in decisions and to be treated more as adults. Yet their ability to make good choices has not been fine-tuned yet, and they still need more direction than what they believe they need. Despite the increases in conflict and decreases in smiling, adolescence is not predominantly a period of storm and stress and turbulence. Relationships with parents, and particularly with mothers, are strained, especially in the beginning. It is suggested that this strained conflict is increased for mothers, since teens tend to spend more time with mothers than with fathers. After the growth spurt, there is generally a decrease in conflict and gripes and angry outbursts. On the whole, adolescents are more in line with the values of parents and society than they outwardly appear. Early maturation is a plus for adolescent boys at the time, because they are valued by their peers and adults for their added strength and size. They have more positive feelings, more social status, more success in athletics. But there is a downside to maturing early as a boy. Because all this success comes so easily, early maturing boys do not practice coping skills and problem solving with the same intensity that late maturing boys are forced to do. They are also expected to be more mature since they look more mature, in a sense pushing them into adulthood too soon. Early maturers also tend to make friends with older boys, which may lead to trouble and more risk-taking behavior. Early maturing girls are not valued for their increased size and strength. At a time when they value fitting in, they stand out noticeably among girl peers, and even more noticeably among boy peers. Early maturing girls may stoop to minimize their height, or to make breast development less noticeable. Some fall prey to emotional difficulties and various problems like depression and eating disorders. When thinness is valued in society, more early maturing girls are impacted negatively because of the added weight that puberty brings. Increased popularity among older boys for early maturing girls can also be problematic, exposing the girls too soon to sexual relationships. The deviant behaviors associated with hanging with an older crowd are more apparent in early maturing girls who have histories of problems established before adolescence. Late maturing boys and girls may have adjustment problems in adolescence, but in coping with them they seem to achieve more successful identities in adulthood. Late maturers have more time to focus on career and achievement goals in adolescence, rather than on physique and stature. At puberty, there is an increase in weight and a decrease in the basal metabolism rate, the BMR, or the rate at which the body uses energy. The BMR is the minimal amount of energy used when in a resting state. The basal metabolism rate drops 15% during puberty, which means less calories are burned for vital body functions like respiration, heartbeat, brain activity, and the production of body heat. Less calories are burned for these vital body functions when the body is at rest. The BMR gradually declines during adolescence and continues to decrease with age, so less food is necessary to meet energy needs. There is a tendency to gain weight as BMR drops or as we age. Adolescents, like anyone else, have different rates for burning energy. Males have higher energy needs than females and need more food. Younger adolescent girls, have energy needs that are higher than older adolescent girls. Set point is a weight factor. Set point is the weight maintained when no attempt is made to gain or lose weight. Set point can be lowered with exercise, making it easier to maintain a lower weight. Exercise is another weight factor and can increase the metabolic rate, helping to burn calories. The higher metabolic rate lasts for hours after the exercise. Aerobic exercise is sustained exercise that stimulates heart and lung activity. Besides lowering the set point and increasing metabolism, aerobic exercise prevents heart disease. It is estimated that exercising enough to burn 2,000 calories a week cuts the risk of heart disease by 67%. 300 calories burned would require swimming or running for 25 minutes, walking for 45 minutes at 4 miles an hour, or aerobic dancing for 30 minutes. During aerobic exercise like jogging, swimming, or cycling, you should aim to raise your heart rate to 60% of maximum rate. Maximum heart rate equals 220 minus the age of the person. Exercise heart rate is the max heart rate multiplied by 60%, or 0.6. An additional benefit of exercise is that it buffers stress. Stressful events have less negative impact on health. Adolescents who exercise regularly have more effective coping skills with stress and more positive identities. Lots of other factors also contribute to weight and eating behaviors: insulin, glucose, carbohydrates, fats, CCK, and the hypothalamus. Insulin levels and glucose levels are factors in eating behaviors. Levels rise sharply when eating simple sugars, but the levels also crash faster, making the person crave more food sooner. Insulin is a hormone secreted by the pancreas that helps regulate the metabolism of carbohydrates, fats, and starches. Eating foods with simple rather than complex carbohydrates increases the desire to eat again sooner. The amount of fat consumed daily should be no more than 30% of the total calories, and diets should include adequate fruits and vegetables. CCK is a hormone that plays a role in satiation, or signals that you are full and no longer hungry. CCK is secreted into the bloodstream and brought to the brain, where it acts like a neurotransmitter, slowing the emptying of the stomach and making the stretch receptors of the stomach more sensitive. Presence of food activates these receptors, giving a feeling of fullness. The hypothalamus is a small brain structure that plays an important role in eating behaviors. Eating disorders that occur in adolescence include obesity, anorexia nervosa, and bulimia nervosa. Obesity is an eating disorder characterized by significant weight gain of 20% or more above ideal body weight for height. It is extremely difficult to treat, yet is the most common eating disorder. Those psychological variables like lack of impulse control, inability to delay gratification, and maladaptive eating styles like eating too fast and eating late at night, even though these psychological variables play roles, the primary cause of obesity for most people is metabolism, which is inherited. People differ in fuel efficiency just as cars do. Efficient metabolism means calories are left over to deposit. Inefficient metabolism means being able to eat large meals without getting fat. 70% of children who have two obese parents become obese themselves. 40% of children who have one obese parent become obese. 10% of children with neither parent obese become obese. 20% of American adolescents are considered to be overweight, with 5% of these adolescents considered obese. Nearly 80% of adolescents who are obese become obese adults. Anorexia nervosa and bulimia are two more eating disorders. They involve a dissatisfaction with body image and or an extremely disturbed image of the body. Anorexia nervosa is rarely seen before puberty. It is self-starvation with very limited food intake. Often victims excessively exercise. Depression, social withdrawal, insomnia, and failure to menstruate in women are other symptoms of anorexia nervosa. Half of 1% of adolescents are anorexic. Victims are predominantly females, with only 5% of anorexic victims being males. Victims are extremely thin, pale, have brittle nails, and are hyperactive and easily chilled. 20% of adolescent anorexics die, like Karen Carpenter. Victims are overachievers and perfectionists. They may feel like they are overcontrolled by parents, and food is one way of gaining some semblance of control. Anorexics have distorted images of their body, believing themselves to be fat, when in reality they are super thin with bones sticking out. Bulimia nervosa is an eating disorder characterized by overeating, then getting rid of food by self-induced vomiting or laxatives. Binge eating and purging leads to permanent damage to the digestive system and gastric and chemical imbalances in the body. 3% of adolescents are bulimic. Victims are not super thin and are of normal or slightly above normal weight. Bulimics cannot control their eating and suffer depression. Health risk factors exist in adolescence. Poor health habits that lead to premature death in adulthood often begin in adolescence. Other behaviors do not wait for adulthood to spew their damage and cause harm during adolescence. The leading causes of death among teenagers are accidents, especially motor accidents, which account for 40% of all teenage deaths. Suicides and homicides, which account for 35% of adolescent deaths. Death by violence is increasing, with African American adolescent males dying as homicide victims and white American adolescent males dying as suicide victims. Partially responsible are the cognitions or beliefs of adolescents, like the underestimation of bad things happening to them. Bad things happen to others. Drug abuse, risky driving, and unprotected sex wreak havoc on other people, not on them. Most of the health problems of adolescents are preventable. Another factor associated with poor health in adolescence is poverty. 16% of adolescents live in poverty. Inaccessible and inadequate medical care goes along with poor incomes. A sense of powerlessness and hopelessness stemming from poverty contribute to poor health behaviors and the mentality of living for today and not taking the time to develop good health habits for tomorrow. In an effort to promote good health in our adolescents, effort needs to be made to prevent smoking habits before they begin. Smoking begun by age 12 years or younger is more likely to become a lifelong, extensive, and intense habit. Cigarettes are pretty easy to obtain. Vending machines do not ask for identification, and neither do many convenience stores. Parents who smoke are more likely than parents who do not smoke to have adolescents who do smoke. Knowing the bad effects of smoking are not enough to prevent the habit. Our adolescents are educated about smoking. They just think being cool and adult-like is more valuable than preventing something bad that is just going to happen to the other guy anyway. TV ads show successful, active lifestyles enjoyed by smokers. Nicotine addiction can be as hard to kick as cocaine addiction. At first, the teenagers are just being cool or fitting in. Once addicted, they are trapped. One school program by the name of Project EX has had some success in the United States and in China. It combines teaching coping skills along with the dangers and harmful effects of smoking. When drug use is the escape means a person chooses to cope with stress, then there is trouble ahead. Competent coping skills are not developed, nor are the skills developed for responsible decision-making. Adolescents who substitute drugs for development of competent coping skills and decision-making skills tend to prematurely enter into adult worlds. They marry and get jobs too soon. They're ill-prepared without the socio-emotional growth necessary for success. Alcohol is the intoxicating element in liquor. It is extremely potent and primarily acts as a depressant or downer, or substance that decreases activity in the body and nervous system. Alcohol is the most widely used drug among adolescents in the United States. Native Americans have the greatest problem with alcohol abuse, and African Americans and Latino adolescents have the least problem with it. In low doses, alcohol can act as a stimulant. In high enough doses, alcohol can kill muscle tissue and brain cells. Alcohol can also reduce inhibition, interfere with judgment, impair driving, decrease intellectual functioning, and control of behavior. At first, a person may be more talkative and socially comfortable, but becomes sleepy and may even become comatose with enough alcohol. Intensity of symptoms depends on metabolism, body weight, and amount of alcohol. Though sexuality does not begin nor end in adolescence, it is an important psychosocial development issue in adolescence. The socialization of sex is demonstrated in permissive, restrictive, and semi-restrictive societies. In permissive societies, there is open sex play allowed among children, which is considered normal. In restrictive societies, sex before marriage is taboo. Boys and girls are separated even for play, and chaperones are always present when they are together. Any sex by adolescents is done in secrecy. Semi-restrictive societies, like the United States, has sex which is formally forbidden. It is not openly discussed, and birth control is not readily available. But adults allow sexes to go to school and socialize together without chaperones. They encourage teens to date and fully expect adolescents to experiment with sex, but to do it secretly. If pregnancy results, then there is trouble, and the couples may be forced to marry. Teenagers do not support promiscuity, and they favor serial monogamy, or sex within one relationship at a time. Adolescent sex usually begins with autoerotic behavior, or sexual behavior with self, alone. Fantasies are popular, so is masturbation. Wet dreams or nocturnal orgasms occur in sleeping boys, but not frequently. After autoerotic sex, sociosexual behavior follows. Sociosexual behavior is sex activities with another. The progression is necking and petting above the waist, touching genitals through clothes, touching under clothes, intercourse, and oral sex. Surveys are not totally reliable. Boys brag and overestimate. Girls underestimate. Rural and inner city adolescents engage in sex earlier than suburban teens. The average age for a youngster's first intercourse in Baltimore's inner city was found to be 11 years old. More than half of teenagers have engaged in intercourse by the time of high school graduation. By age 19, 86% of boys and 80% of girls have experienced sexual intercourse, most with only one partner. There are factors that influence early sexual intercourse before the age of 16. Some of these factors that influence early sexual intercourse before the age of 16 are divorcing parents, single-parent homes, drug use, alcohol use, peers that are sexually active, or the belief that peers are sexually active, siblings, older siblings who are sexually active, no regular church attendance, poverty with little hope in the future, more sexually explicit television and movies, permissive parents with low monitoring, and low intellectual ability, all factors that influence early sexual intercourse before the age of 16. The first experiences with partner sex are different in boys and in girls. In boys, these first experiences are generally brief, impersonal recreation with excitement, satisfaction, exhilaration, happiness, and a sense of achievement resulting. A girl's first experiences with sex has romance, love, and friendship involved, and intimacy, with excitement, happiness, fear, guilt, and worry. Girls can get pregnant, and girls are not supported by their peers as much as boys are. Sexual orientation is the emotional and erotic attraction towards members of the opposite sex, heterosexual, the same sex, homosexual, or both sexes, bisexual. Sexual orientation is the result of a combination of genetic, hormonal, cognitive, and environmental factors. A defense mechanism that adolescents use when they want to hide the fact that they are homosexual is called passing. This is a self-devaluation process that is not healthy. Adolescents pretend to be attracted to opposite-sex schoolmates to conceal their homosexual identity. They may lie to avoid the stigma and ridicule that would come with admitting their true sexual orientation. Homosexuality and bisexuality are not considered to be disorders by the mental health experts. These are not considered mental illness by clinical psychologists and psychiatrists. Research has consistently found no differences in personality or emotional adjustment. 8% of Americans are not exclusively heterosexual, and the percentages have remained constant since the mid-1940s when research about homosexuality began. Homosexuality, bisexuality, not a voluntary choice. No more voluntary choice is involved than heterosexuality being a voluntary choice. So homosexuality and bisexuality, this is not a voluntary choice any more than heterosexuality is. Why would 8% of the population deliberately choose an orientation that is not socially accepted in many arenas? Why deliberately choose to make life harder for self? Homosexuality, bisexuality are established long before sexual activity is experienced and before adolescence has even occurred. Homosexuality is not consistently the result of bad parenting or childhood experiences like sexual abuse from a member of the opposite sex, or pleasant homosexual experiences from a member of the same sex. Homosexuality, once established, is extremely resistant to change. So, sexual orientation is not easy to change. It's extremely resistant. Male homosexuals do not have lower levels of male sex hormones. A gene or genes on the X chromosome may play a role in sexual orientation. Development of children with gay or lesbian parents does not differ from the development of children with heterosexual parents. Children raised by homosexual parents, according to the American Pediatric Association, are no more likely to be gay or lesbian as adults than children raised by heterosexual parents. This research by the American Pediatric Association was done in 2002. This suggests a genetic factor. 1 out of 100 rural Americans are homosexual or bisexual, and 1 out of 8 Americans in the largest cities are. This is not to say urban lifestyles promote homosexuality, only that cities are places where more homosexuals settle. extensive face-to-face interviews with 979 homosexual subjects, 293 women, 686 men, and 477 heterosexual control subjects, found no single condition of family life that appeared critical in the development of sexual orientation. The subjects were questioned about their childhood, adolescence, and sexual experiences. The only common experience among homosexuals was that as children they felt different from others of their sex. The researchers took this to mean a biological predisposition. Adolescents are struggling with the weighty issues of identity, autonomy, intimacy, and sexuality. Homosexual adolescents are in even more of a precarious position since they do not have social support. Gay and lesbian adolescents are harassed and abused both verbally and physically by both adults and peers. Homophobia is an intense, irrational hostility toward or fear of homosexuals, which in extreme cases leads to ridicule, beatings, and murder. Men express more negative attitudes toward homosexuality than women do. The most predictive factor in a positive attitude toward homosexuals was interpersonal contact, or actually knowing or liking or loving one as a friend or a relative before you find out that he or she is homosexual. Higher rates of suicide, substance abuse, running away from home, and school problems are found in adolescents struggling with their sexual identity of homosexuality. There are biological factors. There's a genetic component as evidenced by twin studies. Identical twins had a higher shared incidence of homosexuality than fraternal twins. Hormonal pathways are organized early to favor certain patterns of sexual behavior. Early brain organization and subsequent sexual orientation are affected by prenatal hormone levels. Development of the inner ear is also affected before birth by male hormones or androgens. Androgens also affect brain centers that produce sexual orientation. There is a dramatic difference in the hearing systems of men and women. The cochlea is a key sound amplifier in the inner ear, and in women is more sensitive than that in men. Women are better at hearing very soft sounds in a very quiet room, even female infants. Early research has found that lesbians do not hear these sounds as well as heterosexual women do, but they hear them better than men do. The presumption is that when the auditory centers are masculinized, so are the sites that direct sexual preferences. There is biological, environmental, and social interaction. Inborn predispositions channel children to choose certain play activities and friends which lead to homosexuality orientation. For instance, avoiding rough games. A parent-child relationship is altered due to the child's predispositions to non-conform to traditional gender role behavior. This alienates parents and same-sex peers. Differences found in the hypothalamus of gay men versus heterosexual men can be the result of living or experience rather than biology. Research was done post-mortem or after a lifetime of living. Bem's theory of sexual orientation maintains that the same basic processes underlie homosexuality and heterosexuality. Bem is not interested in what causes homosexuality, but what causes the varieties of sexual orientations in general. An important aspect of Bem's theory of sexual orientation is that it shows what a biologically informed theory of personality should look like, and illustrates the interaction of many different kinds of elements to produce sexual orientation. Many different kinds of elements like biological, personality, social, and sociological influences. There are 6 developmental stages. The first is the biological one. A child begins with genes and prenatal hormones. The second developmental stage, childhood temperaments. Aggression, activity levels, and personality styles are formed in response to genes and prenatal hormones. The third developmental stage, societal interaction and formation of playgroups. Sex-typical and atypical activity are determined by culture and society. Playmate preferences and gender conformity and nonconformity are experienced. Societal segregation of playgroups by sex are established by age 5. The next developmental stage of sexual orientation, feeling different from opposite same-sex peers under the demands of the segregation of playgroups. 63% of homosexual men and lesbian women claim to feel that they do not fit in with the same-sex group. Only 10% of heterosexual men and 15% of heterosexual women claim to have felt this not fitting in. So the homosexual orientation individuals were more interested in the activities of the opposite sex group, so they hung out with it rather than the same-sex group. The same-sex group then became dissimilar, unfamiliar, and exotic. The next developmental stage, non-specific autonomic arousal that comes with novelty. Whichever peers are the most novel, or were interacted with or experienced less, are the ones that promote non-specific autonomic arousal. This response to novelty is a universal emotional mechanism. And the final developmental stage, erotic romantic attraction to opposite or same-sex persons, sexual orientation. The non-specific autonomic arousal that comes with novelty is translated or labeled to mean sexual attraction to whichever peers are the most novel, opposite or same-sex peers, depending on whom was interacted with or experienced less. Adolescents are neglected and abused sexually, physically, and emotionally more often than younger children. Adolescent victims of rape are more often female and more often poor. Added risk factors are living away from home by age 16, having physical or emotional disabilities, and having parents who are alcohol or drug abusers. Rape is the forcing of an unwilling partner to have sexual intercourse. Among the common characteristics of rapists are aggression with a sense of power, anger at females in general, and a desire to hurt their victims. A characteristic not commonly found is remorse after committing a rape. 50% of college men admit to having forced sexual activity. Included in this is date or acquaintance rape, which employs various psychological measures and physical behaviors to coerce a woman to having sex even though she says no. 50% of rape victims later experience sexual dysfunctions. Recovery depends on a victim's coping resources and her level of adjustment before the attack. If you take all non-voluntary sex and not just rape into consideration, 25% of all girls and about 10% of all boys have been victims either in childhood or adolescence or both. Victims of sexual abuse are more prone to suffering low self-esteem, academic trouble, anxiety, fear, and depression. They are also more prone to taking chances with risky behavior, as well as becoming pregnant while still teens. One out of every 4 teenagers develops an STI, sexually transmitted infection, or an STD, a sexually transmitted disease, before high school graduation. So STDs are quite common. They can be parasitic, which means they can be cured with special shampoos. Pubic lice causes intense itching in pubic hair that can be cured. Bacterial STDs or STIs can also be cured. Antibiotics enter into the picture here and cure bacterial STDs. Chlamydia is the most common bacterial STD found in both sexes, and one that can cause infertility in females. Chlamydia attacks the genital organs. 4 million new cases are found among Americans yearly. 10% of all college students are infected. It is highly infectious, with a 70% chance of infection with only one exposure in women, and a 25 to 50% chance of infection in men with one exposure. Often, there are no symptoms in females, which gives a false sense of security, leading to females not seeking treatment and then suffering infertility due to the untreated damage. Men and women may experience painful urination and burning, plus there may be vaginal discharge in women. Gonorrhea is another bacterial STD. It's also called drip or clap. It's caused by a bacterium from the gonococcus family. It thrives in mucous membrane areas like the mouth, throat, vagina, cervix, urethra, and anal tract. The early stages of gonorrhea can be successfully treated medically with penicillin or other antibiotics. Women have 40% and men 10% chance of catching gonorrhea with the very first exposure. Within 3 days to a month after exposure, men develop a pus-like discharge from the penis, painful urination, blood in the urine, aching pain or pressure in the genitals, swollen lymph glands in the groin. 80% of women do not have early symptoms, allowing more damage to be done before treatment. Left untreated, gonorrhea causes pelvic and reproductive infection within 2 months in women, and infertility and scarring of the fallopian tubes may result. Syphilis is still another sexually transmitted disease. It's caused by a bacterium, a member of the spirochete family. It progresses through 4 stages and, if untreated, can eventually be fatal. The 4 stages are primary, when there is a painful sore at the site of the infection that heals in 4 to 6 weeks and gives the false impression that all is well. The 2nd stage is called secondary. There's a painless rash with fever, sore throat, loss of appetite, fatigue, headache, swollen glands, joint pain, and hair loss. This secondary stage lasts 6 weeks. If penicillin treatment has not been started in the primary or secondary stages, then syphilis goes into the 3rd stage, called latent. The bacterium goes into latency for years. After 2 years, syphilis cannot be spread with sexual contact, but can be passed from a pregnant woman to her fetus after the 4th month of pregnancy. 30 to 50% of syphilis victims go on to the tertiary stage. This is the fourth stage. Tertiary is accompanied with blindness, paralysis, heart failure, mental illness, and death. Penicillin will not work at the third and fourth stages. It will not work at the latent and tertiary stages. Viral STDs cannot be cured with antibiotics. Genital warts are caused by the papillomavirus. Genital herpes, usually caused by the herpes simplex virus type 2. Type 1 usually causes oral herpes and cold sores and fever blisters in the mouth. Genital herpes results in painful blisters on the genitals and is recurring and most highly contagious during outbreaks. 75% of people will develop genital herpes themselves after only one exposure with an infected partner. 3 to 5 days after infectious exposure, itching and tingling may occur, followed by sores and blisters on the genitals, thighs, and buttocks. This lasts about 3 weeks. During dormant times of no blisters and open sores, the virus travels up nerve fibers to the base of the spinal cord until it strikes suddenly again. The first attack is usually the worst one. Severity and frequency of attacks can be helped by the antiviral drug acyclovir. Genital herpes can result in blindness, encephalitis, and an infected baby. A cesarean section must be performed to prevent herpes infection in a baby of an infected mother. Females with genital herpes are 8 times as likely to develop cervical cancer as other females. 100 million Americans are victim to type 1 herpes. 1 million are victim to type 2 herpes. There are 600,000 new cases a year. AIDS is the STI or the STD of greatest concern. 100,000 die each year from AIDS in the United States alone. Though victims are rarely teenagers when they die, those with symptoms in their 20s were exposed to AIDS in their teens. There is an average 10-year latency period, or as much as 15 years. AIDS stands for Acquired Immune Deficiency Syndrome, a fatal viral infection that reduces the immune system's ability to defend itself against invaders. The first reported U.S. cases were in 1981, though there were some before this date. In 1984, the cause of AIDS was determined to be HIV, human immunodeficiency virus. In 2003, the largest number of new cases worldwide in 1 year was reported, nearly 5 million cases. Also in 2003, 3 million people died with AIDS worldwide. Since the beginning of the AIDS epidemic, more than 20 million people have died worldwide. Rates of new cases are rising sharply among heterosexuals in China and India. Almost 50% of HIV-infected victims are women. AIDS is the 5th leading cause of death in Americans aged 25 to 44. It is the 3rd leading cause of death among African American men aged 25 to 54 and African American women aged 35 to 44. The rate of HIV infection in the United States is 17 times higher among African American and Latino women than among white women. Alarmingly, 1 in 300 city college students are estimated to be infected with HIV. In 2001, Americans infected with HIV was 800,000 as reported to the CDC, and 40 million in the world. AIDS can only be contracted if the virus is introduced by blood, semen, or vaginal secretions directly into the bloodstream, not through shaking hands or hugging or casual contact. The 3 primary ways of spreading HIV is through unprotected sexual intercourse, use of infected blood or blood products, and sharing of syringes. Anal intercourse spreads the virus more readily than vaginal intercourse because the body tissue has a more fragile lining and tears more easily in the rectum, giving HIV an entry point. Generally, an HIV blood test will show positive within 12 weeks of exposure, but may take 6 months to show positive. For HIV to become full-blown AIDS, it may take 2 to 15 years or more. The disease progresses faster among smokers, among the very young, in people over 50, and it seems in women. Also, there is faster progression due to repeated HIV exposures and contracting HIV from one whose age is advanced. HIV is transmitted more easily from infected men to women than from infected women to men, but it can occur either way. The only effective means of fighting AIDS right now is prevention and changing people's beliefs, attitudes, and risky behaviors. Thus, the role of psychologists is crucial until a cure is found. Education is not enough, since people who know the risks take them anyway. Denial, or "it couldn't happen to me," is partly responsible. So is the failure to delay gratification and resist temptation. Because they do not want to delay gratification, people will engage in more denials and rationalizations like, "He looks healthy. She's not that kind of person. He or she wouldn't lie to me." Those who choose to be sexually active should have condoms, sturdy ones, not cheapies, readily available, and make sure they are used every time. Though this does not give 100% protection, it certainly is a lifesaver. The only 100% guarantees are abstinence or a monogamous, mutually faithful relationship with an infection-free partner, and none of these adjectives can be dropped. Drugs like AZT, in combination with other antiviral drugs and protease inhibitors approved by the FDA in 1996, seem to slow HIV's progress. Almost all teenagers have tried alcohol, and 2/3 have tried cigarettes. 50% of all seniors have tried marijuana. The Center on Addiction and Substance Abuse reports that most teens who use alcohol, cigarettes, and marijuana do so before they are 14. Among teens who have tried alcohol, tobacco, or marijuana, the average age of first use is a little more than 12 for alcohol, 12 and a half for cigarettes, and 13 years, 11 months for marijuana. Risk factors for becoming a substance abuser crosses lines of sex, social class, and ethnicity. The same factors are risks for all groups and are grouped in 3 sets: psychological factors, interpersonal factors, and social context factors. Psychological. Certain personality characteristics predispose a child to later abuse drugs. These personality characteristics can be anger, impulsivity, depression, and academic problems as well. Interpersonal factors. Hostile, authoritarian, and distant permissive parenting relationships contribute to the incidence of substance abuse in adolescence. So do relationships with peers or siblings who use drugs. And the factor of social context. Easy access to drugs and environment that tolerates drug use also contribute to substance abuse in adolescence. Parents who abuse drugs or alcohol themselves are providing a social context that allows easy access to drugs and alcohol, and in addition, tolerates their use. Homes where parental monitoring is compromised and stress, violence, or conflict run high provide a social context which increases an adolescent's chance for substance abuse. The total elimination of drugs and alcohol from society is not realistic. The two largest problems, alcohol and nicotine, are legal and easy for adolescents to acquire. The laws against selling alcohol and cigarettes to minors are not strictly enforced, but research has shown that raising the selling price of these items does reduce adolescent use of them. There have been indirect and direct approaches to preventing substance abuse. Abuse means excessive and frequent use rather than the experimentation use that has become normative. Indirect programs aimed at increasing self-esteem or encouraging gainful employment have not been successful. Neither have more direct approaches been successful, like educating youth about the dangers of drugs or teaching social skills necessary to turn down drugs. Project DARE is the most widely used drug education program and is ineffective. Youth do not respond well either to scare tactics or to education. At least they do not respond well behaviorally despite added knowledge. Programs that aim at the significant others of adolescents, like parents, peers, and teachers, have more chance at success. If the environment of the adolescent is not addressed, then there is not much hope for preventing substance abuse. Any drug abuse program should include the family and not just the teenager. Peer-led programs should be conducted also. Protective factors which help prevent substance abuse are high self-esteem, absence of depression, high academic achievement, close family relationships, gainful employment, and involvement in church activities. Just as influential on adolescent development as puberty is the expansion of thinking abilities, cognitive transitions. There are 5 main ways that the thinking or cognition of adolescents is more advanced and different from the thinking of children. 1. Adolescents are able to think about what is possible as well as what is real. 2. Adolescents can think abstractly. 3. Adolescents have metacognition, are able to think about the process of thinking. 4. Adolescents are more able to think about several things at once. And 5. Adolescents are able to see things as relative rather than strictly absolute. Now let's take each one separately. The first way adolescents differ from children in cognition is that adolescents are able to think about what is possible as well as what is real. They are no longer limited to concrete, hands-on events. They are in Piaget's formal operational stage of cognitive development. Logic for them now resembles that of scientists. They use hypothetical deductive reasoning, which means they consider all the factors of a problem which may contribute, and then systematically evaluate all the possible solutions. They devise alternative solutions, not one and only one answer, and decide which plan may be the most effective. They make better Wheel of Fortune contestants than children who are in the concrete operational stage because they systematically choose letters and not haphazardly guess. If you were to give them a task to come up with as many combinations of 3 numbers, teens in the formal operational stage would solve the problem in an ordered way, choosing one number to be first and exhaust the possible combinations, and then the next number would be first and the remaining numbers jockeyed. Concrete operational thinkers, younger children, would choose number patterns haphazardly, like the ones they liked or were familiar with, and would end up with repetitions and omissions. As an adolescent becomes more of a hypothetical thinker, an if-then thinker, the adolescent becomes a better arguer. He or she no longer accepts the views of others automatically without question, even those of authority figures and parents. Adolescents pose alternative beliefs and think ahead defensively to be a step ahead of their opposition. As hypothetical reasoning becomes sharpened, adolescents become better decision makers. As for decision making, adolescents are more skilled at making competent decisions than they were as children. They consider extenuating circumstances and other factors and sources that may influence a situation. Plus, they consider alternative options and the consequences of each. Adolescents may be quite competent in making decisions about academics and schoolwork. However, they are not as competent in making decisions in practical everyday life where experience counts. This is evident when you consider that adolescent cognitive and motor skills are enhanced in driver's ed classes, but yet their auto accident rate is high. The second way adolescent thinking is more advanced than the thinking of children is that adolescents can think abstractly. They can think ideologically about things that are not directly experienced through the senses. They can now go beyond actual concrete experiences and think abstractly. Their thinking can include things like algebraic equations and political cartoons and literary proverbs. They can now look beyond the literal meanings of stories like Aesop's fables and see the underlying morals. They can imagine worlds that never were, and there is a surge of interest in science fiction and fantasy role-playing computer games. Being able to think abstractly allows for greater social cognition. Adolescents can speculate on what they consider to be ideal worlds with ideal parents and teachers, utopias. Idealism reigns supreme, accompanied by a confused dilemma in deciding on which ideal standards to adopt for themselves. In their ideal world, there is no room for tragedy, affliction, and disasters. These things happen to other people rather than to them. The third way that adolescent thinking differs from the thinking of children is metacognition. Adolescents have metacognition, are able to think about thinking. Metacognition includes being aware of whether or not a solution is working, or whether or not there is change in approach needed, a different angle. Adolescents employ better strategies for remembering something. They use introspection to evaluate their own emotions. Using intellectualization, they evaluate their own knowledge and comprehension. They also think about how others think about them. Before adolescents are adept at using their new metacognition skills of introspection and intellectualization and thinking about how others think about them, they experience something called adolescent egocentrism. Some people do not shed adolescent egocentrism when adulthood is reached. Adolescent egocentrism is increased self-consciousness of adolescence. It is divided by David Elkind into two types of social thinking: the belief that others are just as interested in them as they themselves are, the imaginary audience concept, and the belief that they are unique, the personal fable concept. Imaginary audience is a belief that everyone is just as interested in you as you are. Teens with adolescent egocentrism genuinely believe that when they walk into a huge gymnasium, everyone's eyes are focused on the zit on their nose or riveted to the cool new t-shirt. Teens will agonize for hours over what to wear and whether they have worn each item recently. If they cannot remember, how do they expect others to do so? For some teens, this necessitates attention-getting behavior and risky behavior in order to get noticed, to be seen, to be on stage. For others, it means withdrawing and avoiding people. Personal fable is the sense of uniqueness. No one understands how they really feel. Sometimes adolescents create fictional stories in their diaries, fantasizing in an unreal world. Adolescents perceive themselves to be uniquely invincible, invulnerable, and superhuman. Things happen to others, not to them. Laws apply to others, not to them. Personal fable helps explain risky behavior like speeding or unprotected sex. Research shows that adults are just as likely to employ a personal fable as adolescents are. The fourth main way that adolescent thinking differs from child thinking is that adolescents are more able to think about several things at once. They can use and understand sarcasm and satire. They can consider multiple dimensions at the same time. They can enjoy tasteless, risque jokes that have more than one meaning. They can appreciate satire. Favorite shows include South Park, Beavis and Butthead, and The Simpsons. Language changes to include satire, metaphor, sarcasm, irony, and wit. They use language that has double meanings or exaggerations. They make up nicknames and labels for teachers and each other, and their own terms like spaz, biatch, frickin', chillin', fag, crack-a-lackin', G'd up, homie, my bad, trippin'. These are used frequently. They are also perfectly capable of using polite language in socially appropriate ways. This can be quite genuine, or can be the Eddie Haskell, Leave It to Beaver type. Thinking in multiple dimensions brings with it an increased propensity for writing. Writing skills improve considerably in adolescence. There is more organization and skill in both writing and language. Teens can tell and write better stories and jokes, and they can fabricate better lies. The fifth main way that adolescent cognition is more advanced than their thinking as children is that adolescents are able to see things as relative rather than strictly absolute. They question, criticize, and are extremely skeptical. Beliefs once held without question are laced with doubt as they search for answers. They may not have questioned the use of drugs before, but now consider each drug on an individual basis. Marijuana is judged less problematic than cocaine or heroin or alcohol. Breaking a traffic rule depends on whether or not the rule makes sense, like running a lengthy red light when there is no vehicle around in any direction for blocks. Early adolescent thought is quite different from late adolescent thought. Early adolescent thought is not realistic. Idealism and utopias cloud reality, and the child or the teenager uses assimilation quite a bit, perceiving the world too subjectively and idealistically. Things are right, wrong, black, white, we, they, good, bad. This dualism allows for no middle ground, no gray area, no multiple perspectives, and little tolerance for opinions that differ from their own. Later adolescent thought seeks for more of a balance between idealism and realism. Reasoning is tempered with experience. It is not enough to think about unlimited possibilities. Probabilities are considered as well. Balance or equilibration is reached. Much of what we have talked about concerning cognitive development of adolescents can be found in the formal operational stage of cognitive development proposed by Jean Piaget. Piaget stressed four main stages of cognitive development: sensory motor, pre-operational, concrete operational, and formal operational. These stages involved qualitative change, transformation in kind of cognitive ability, not simply quantitative change or increasing the amount of abilities already existing. Piaget talked of cognitive skills in adolescence that were different from those of children, that were qualitative, not simply more advanced cognitive skills, but different cognitive skills. We've talked about the qualitative developmental changes that Piaget proposed. There are 6 quantitative developmental changes that information processing theorists propose. These 6 quantitative developmental changes set adolescents apart from children. The first quantitative developmental change is the ability to pay more attention, the ability to focus and to filter out interfering stimuli. The second quantitative developmental change in information processing that set teens apart from children is that memory abilities improve. Processing capacity increases. Processing capacity is the amount of information that can be processed at once. Processing capacity is limited to 7 plus or minus 2 pieces or chunks of information. Adolescents are more skilled at chunking information to increase the capacity of their short-term memory than they were as children. Chunking groups individual items into meaningful larger units. For instance, if I were to tell you to write and remember this series of letters, A, P, D, I, B, O, H, G, T, you would not be as able to than if I were to change the task. If I were to tell you to remember these same letters, but yet I use chunking, you can remember so much more easily. D-O-G, B-A-T, H-I-P. Same letters, but I chunk them. The third quantitative change is that processing speed increases. An adolescent can process information faster than children are able to do so. Contributing to this increased processing speed are the facts that adolescents have had more practice and need less time searching for information. The fourth quantitative change is that organizational strategies are employed more. Mnemonics, techniques to increase memory, are used more often and more efficiently. Planning ahead using strategies to solve problems is done rather than diving in head first. Metacognition is the fifth quantitative developmental change in information processing. Metacognition is thinking about own thinking processes. It improves so that adolescents can monitor learning and can slow down, speed up, repeat, skip ahead, etc. Cognitive monitoring is keeping tabs on, keeping stock of what you are doing or thinking at the moment, what you plan to do or think next, and how effective this plan of mental action or thought is turning out to be. Metacognition includes being aware of whether or not a solution is working and whether or not there is a change in approach needed, a different angle. Automaticity is the sixth quantitative developmental change. Automaticity refers to behavior requiring little or no effort. Automaticity is more frequent in adolescence than in childhood. It helps free attention for other things. Adolescents have more of their capacity freed for higher level thinking, spending less time focusing on lower level processes like identification of stimuli. There are two critical components of information processing which help determine which information will be dismissed after it leaves short-term memory and which will be processed further into long-term memory. These two critical components, attention and perception. Attention is the focus on a stimulus. It is a very limited resource. We cannot pay attention to everything, or life would be quite difficult. We would be unable to filter out the unimportant or irrelevant stimuli, and would become overloaded or overstimulated constantly. We thus say that attention is selective. We also say that attention is shifting. We can shift from one topic to another. Also, attention is needed more in the beginning of information processing. After information is learned or encoded, then less attention is necessary, freeing capacity for other things. The more something is practiced, the more automatic it becomes, and the less attention is required. Perception is the interpretation or meaning of information using pre-existing knowledge and present reality. We practice perception by organizing incoming information into a meaningful whole, connecting it when possible to existing stores of knowledge. The cognitive changes that take place in adolescence influence the everyday social cognition of teenagers in three main ways. Social cognition is how people think and reason about their social world. The first main way that adolescent cognitive changes influence everyday social cognition is with impression formation, judgments of other people. Adolescents develop a theory about why people think and act the way they do. They develop an implicit personality theory, the lay person's view of personality. Adolescents interpret the personality of people differently than they did as children in several ways. Among them are they do not rely solely on the information at hand, but consider previously acquired information and current information. They do not believe personality is always the same, but pay attention to the context and situations that make personality variable. They do not accept surface visible traits as valid indicators of personality, but also look for deeper hidden factors. The second main way that adolescent cognitive changes influence everyday social cognition is with social perspective taking, assessing the judgments others make. Social perspective taking is the ability to assume another's view or perspective and understand his or her thoughts and feelings. Perspective taking allows adolescents to understand the needs of others and to communicate more easily and effectively. It enables teens to improve their status with peers and to participate in more stable friendships. It allows family communication to improve. Adolescents with social perspective taking will couch requests or favors using reasons that would benefit the parents rather than themselves. For instance, if you get me my own line, your line will be freer for you. If you loan me a few bucks for the movie, I'll be out of your hair for a while. If you allow me to use the car, I'll stop at the grocery for you on the way back. Social perspective taking allows an adolescent to understand how coming in when expected prevents worry in the parent. Of course, then they may work on changing the time that the parent expects arrival home. The third main way that cognitive changes influence everyday social cognition in teens is with morality and social conventions, ideas of justice and caring. At first, an adolescent may not agree with social conventions and rules considered petty or arbitrary or no big deal. Why wait in long lines just because everyone else is doing it? Why be polite? Why pay for something if the store has so much of it and will not miss it? Eventually, an adolescent will see for self that social rules and conventions have a necessary purpose, that they protect the rights of everyone. Rules prevent certain people from getting unfair advantage, and these same rules protect everyone. Lawrence Kohlberg stressed the importance of cognitive development in morality and in understanding social development. He is best known for expanding Piaget's theory to account for morality. Emphasis is on the progression of justice and fairness. Carol Gilligan expanded upon Kohlberg's theory by emphasizing the progression of caring rather than justice and fairness. Another important thing to consider with social cognition is social cognitive monitoring. Social cognitive monitoring presupposes that the adolescent has acquired the ability to think about others' thoughts and feelings as well as his or her own. Teens monitor or evaluate their social world with an increased awareness of themselves and others. The better they are able to keep tabs or monitor their social world, the more competent and mature they are in social situations. Adolescents are known to take more risks than adults, though not differing in decision-making capabilities or sense of invulnerability. Reasoning steps are the same, and sense of bad things happen to others, not me, is the same also. The difference in risk-taking behavior between adolescents and adults may be explained by their differential regard for the consequences. Adolescents place more value on certain things than adults do. Adults may view the physical health consequences of alcohol and the legal ramifications for underage drinkers. Adolescents may be aware of these consequences, but other consequences, like being branded a nerd or a loser, carry more weight and seem more relevant to them. Teens also may not have as accurate an idea of consequences due to less experience. Adolescents are higher in the emotional quality of sensation seeking than are adults. High sensation seekers need intensity and novelty much more frequently than do others. They get a thrill and a rush out of living a bit on the edge. These adolescents would be more inclined to engage in risky behavior, not for the purpose of danger, but for the purpose of a new and exciting change. Adolescents during puberty have neurons that are more sensitive to excitatory neurotransmitters. This helps explain why teens react more intensely to stress and to pleasure, and perhaps why they seek novelty and reward. Schools for teens. Less antisocial behavior and more prosocial behavior occur in smaller schools. Students achieve more and behave better in smaller sized schools. They have more of a tendency to bond with the school and feel loyalty or allegiance. Students are more likely to be active in a wide range of activities. They are more likely to rise to leadership positions. Students with low achievement or marginal grades are likely to participate and join in activities, feeling a sense of involvement and commitment that matches the higher academic achievers. This is in small schools. Large schools offer other advantages. They offer more material resources, more curriculum choices, and many more non-academic activities like clubs and teams and organizations. But despite more non-academic activities offered, actual participation is proportionately much smaller than the participation in smaller schools. Large schools are less personalized and are less responsive to good behavior. They do not recognize desirable behavior with rewards as often as smaller schools, resulting in higher crime rates. Since the school is less personalized, it has less effective social control over students. The ideal school size for adolescents appears to be between 500 and 1,000 students. Small classroom size with few students is not as critical as believed, except for remedial classes or tutoring or for the first years of elementary school. Adolescents have been shown to learn just as much in classes of 40 students as they do in classes of 20. Just reducing the size of a class will not appreciably change things unless changes in instruction are also done. Since few schools can afford the additional staff demands that classes of 20 or less would require, an alternative measure would be to concentrate funds on subjects that are most critical. Math, English, and science classes would be smaller, and elective classes larger. The transition from elementary to junior high, from junior high to high, and from high to college involves a stressful condition known as the top dog phenomenon. The top dog phenomenon is experienced when a student moves from being the high person on the totem pole to the lowest one, from being the biggest, oldest, most powerful to becoming among the smallest, youngest, and least powerful. since there is considerable stress every time a youngster goes through such a transition, and since this is compounded if the transition coincides with the onset of puberty, it is probably best if children could remain in one school from kindergarten to 8th grade, and then switch for 9th through 12th grades. This old two-tier system of education reduces the number of transitions necessary, plus it places the major transition well past the onset of puberty. A research study compared the students in school systems with an elementary, middle, and high school arrangement with students in school systems with a two-tier arrangement. The results showed that those students who were in the two-tier system and only had to change schools once had higher self-esteem and more extracurricular participation than those children who were required to change schools twice. Grades went down also with a school switch. School transitions have a temporary negative effect, but the earlier the transition is in adolescence, the harder it is for children to adjust and overcome the negative influences. It is not just the timing and transition that negatively affects children. The school the elementary child moves up to may be radically different. The middle school or junior high school is larger, less personal, more rigid, more anonymous, with teachers who focus more on discipline and control. Teachers have bought into the myth that adolescents are difficult kids, disobedient, defiant, hard to teach. Teens are taught to, like the adults, have chips on their shoulders, fully expecting them to be knocked off and determined to be one step ahead of the teens. An incident that comes to my mind right away happened in a middle school's office. I was in the office for some reason when a youngster came in with a terrible headache and asked for some Tylenol. The way he was talked to and questioned by a teacher and a secretary who were behind the desk, I do not even use with my dog. "You should know we cannot give you anything. Call your mother." The boy hung his head, probably because his mother was unavailable, and turned to leave. As he went out the door, he conked his head pretty hard accidentally. As the door closed behind the boy, the teacher laughed, and he remarked, "Well, if his head didn't hurt before, it sure hurts now." There was no compassion, sympathy, empathy. Surely I'm not suggesting that any pain medication be administered, but the child could have been talked to humanely. Why not allow him to place his head down for a few minutes, just in an effort to say you really feel for him? 2 of my 7 children have had problems with migraine headaches. These are no laughing matter. Among the mediating factors which diffuse some of the negative influences of schools for teenagers are schools which supply support, are less complex, with less anonymity, parents who show interest and involvement in a child without stepping on their attempts to become autonomous or independent. Another mediating factor, adolescents with higher quality friendships and frequent contact with friends, adolescents with extracurricular activities like jobs and sports and clubs that do not overdo, thus competing with academics. All these are among mediating factors which diffuse some of the negative influences of schools for teenagers. "50% of adolescents pursue higher education after high school. 2/3 of them get a degree. Half of college dropouts do it before their second year of college. College is a huge transition requiring even more depersonalization, being just a number. For many students, college coincides with being away from home for the first time and having to be in charge of finances and home duties. Starting new relationships and breaking relationships may also be happening at the same time. To reform public education, we do not need more tests and escalating punishments for substandard schools. We need, among other things, more equitable appropriation of public funds, implementation of academic programs with a high success record, lowering pupil-teacher ratio for reading and math, and higher pay incentives for seasoned teachers willing to teach in substandard schools. We need to address individual needs of students at the first signs of struggle. Learning is supposed to be fun, and frustration is a red flag that all is not well. We need reinforced inclusion with special education experts and properly trained paraprofessionals available for teamwork with classroom teachers. No more dumping, please. Universities need to be non-judgmentally lending their services to drowning schools. And the personnel at these schools need to interact with and accept the help graciously. We need local and state school boards to investigate more fully the psychological and educational impact of laws and procedures so that the counterproductive ones are discarded. Those like tracking, whole class punishment, and too much nightly homework. Relevant, effective class management skills need to be established in all teachers so that discipline is relied upon less. Discipline must be based on sound educational and psychological principles, such as negative reinforcement works better than punishment, and punishment must be immediate to be effective. There needs to be an intermediary system to handle struggling, misbehaving students who are not responding well. Rather than zero tolerance or suspensions and expulsions, chronically disobedient students are temporarily removed from class sooner. Rather than being awarded unsupervised free time on the streets, they are given structure and academics, as well as whatever they personally need to counteract the root problem. Conflict resolution, behavior modification, anger management, drug counseling, coping with stress, depression, anxiety, specialized tutoring, study skills training. Too expensive? 1 year in prison costs states 3 times more per person than what is spent on educating one child for 1 year. This is according to the Children's Defense Fund. A structured intermediary system to handle troubled children until they are able to learn with behaving peers will divert some of our disposable youth from a sure path to prison or the morgue. No child is dispensable. %15 of Americans aged 25 to 29 have not finished high school, with Native Americans having the highest rate of dropouts. Only 1 in 10 Native American children graduate from high school. The most likely reasons for dropping out of high school are due to school-related reasons like not liking school, being suspended, or being expelled. Zero tolerance is nonsense. We need an interim structured system, even on-site, to give conflict resolution, cognitive restructuring, behavior modification, social skills training, anger management, tutoring, learning disability aid, etc. The next most likely reasons for dropping out of school are economic, especially for Latino children. Students drop out to go to work to help support their family. In a large study in 1991 of 30,000 sophomores followed through to graduation, dropouts were found more probably to come from low SES, low-income families, to be in vocational programs, to be male, to be an ethnic minority with the exception of Asian American, to attend a city school, to have lower grades, especially in reading, to be disciplinary problems, to do less homework, to have less self-esteem, to have fewer educational expectations and goals, to have external locus of control, meaning forces beyond their control decide their fate. So these were the factors that were found to be these are the factors that dropouts were more likely to have. SES, socioeconomic status, refers to levels or classes of society based on income, power, background, and prestige. With low SES comes more than a lack of money. Poor health care, more stresses, more school interruptions and absences, discrimination for non-cool clothes and shoes, and grammar mistakes, and low expectations from teachers, and low self-esteem, more learned helplessness. All these factors go along with low SES, so it's far more than a lack of money. There are also different child rearing styles in different SES levels. Low SES parents talk less to their babies and children, providing a non-stimulating atmosphere. They explain less, give fewer choices, less encouragement, less reading, less library trips. They command more and teach less. The authoritarian parenting style is more evident. SES has a notable positive correlation with school achievement, but actual attitudes and behaviors of a child's family life seem to be more important than income or lack of it. Bridging the gap between school and work for non-college bound students can reduce the dropout rate. Monitored work experiences and school volunteer programs within high school curricula help.